Okay, hello everyone. Welcome to the hot seat, part two. I'm joining you all from Tehran and our dear guest and the great speakers and researchers. Alberto Monje is joining us from Spain in the part two of the hot seat. We have participants from around the world and a very comprehensive presentation by my dear friend Alberto. As a tradition, I have a brief introduction of Alberto. He's the director of the Division of Periodontology, but diplomate of the American Board of Periodontology, assistant lecturer, Department of Periodontology, University of Catalonia, and he has his Master of Science in Periodontology from University of Michigan. Also, he's adjunct clinical professor at the Department of Periodontology, University of Michigan. I'm so happy to have Alberto with us, and I'm looking forward to his presentation with the topic of soft tissue augmentation around periimplantitis patients and cases. Alberto, we are ready for your amazing presentation.
Well, thank you very much, Omid. It is my very big pleasure to have you as an introductor for me. I wish we could be joining in Iran, so I'm sure that we'll have the opportunity in the near future, hopefully, when all this goes away. And it is a great pleasure to be online here with you. I want to thank you, of course, for this very kind initiative in this awkward and somehow bluffing situation which we are living worldwide. And we have to thank God somehow, of course, to be healthy and to be safe at home. So are doing well and are a way of suffering of this disease, of this virus, which is of course something that we have to be aware of, and we have to be of course concerned of how to prevent this type of patients in the near future that come with this disease as well. My primary purpose will be the significance of soft tissue characteristics on peri-implant health. As a secondary goal, soft tissue augmentation interventions that we can use on a daily basis, some of them more invasive and some of them minimally invasive, and perhaps we can name them as graftless, in order to soft tissue conditioning, which this is something very crucial, not only in the prevention, but also in the management of periimplantitis. Because we have to conceive periimplantitis as a biofilm-mediated inflammatory condition that, as far as we know, it causes soft and hard tissue breakdown. At the beginning, which often is reversible in an effective manner, but takes longer than the resolution of gingivitis by means of a mechanical therapy. But if this is not managed accordingly, we'll have this scenario of periimplantitis, where there is progressive bone loss beyond the initial bone remodeling, to analyze the epidemiology of this entity, of this disease, because we know that there is approximately worldwide about 2 out of 10 patients may have this pathology. But the interesting thing is not only to assess the prevalence, but it's the key for understanding this disease, and is that we are dealing with a site-specific entity. This means that contrary to the vast majority of forms of periodontitis, where we know that bone loss occurs in an even manner, homodentition, when we have periimplantitis, it's probably going to be happening in 1 or 2 implants in those individuals that have 5, 6, or 7 dental implants. This means that this is not often a generalized disease. Of course, this is contrary also to preliminary findings of the studies that are being carried out in China, in Europe, and also in North America, that coronavirus has courses with a bilateral disease of the lungs, with this type of disease. And this, of course, has led to equivocal epidemiologic data where the prevalence at patient level is often 2 or 3 times greater than the prevalence at implant level. And that's something important to understand disease, because even though we know that there are certain indicatives, as were shown by Jan Dirks in this we can say, classical article that showed that those patients that have more than 4 implants are going to have an odds ratio of having periimplantitis in about 18 to 19 times greater. Those implants placed in the mandible are exposed to 2 times more periimplantitis than those implants placed in the maxilla, that can lead to look after disposing factors. And in this sense, the emergence profile, for instance, has been named as one of these local predisposing factors. Implant post, not less important, being the quality and the characteristics of these soft tissues. Generally speaking, we know soft tissues in the oral cavity are characterized by stratified squamous epithelium, where if we have a keratinized mucosa, we're going to have 4 layers, namely from the basement or from the proximity of the lamina propria. We're going to have the stratum basale, the stratum epithelium, the stratum spinosum. And of course, if we have keratinized tissue, that means that we're going to have 2 more superficial layers. We're going to have the stratum granulomatosum, and it's in this layer where these keratinocytes are going to undergo differentiation and are going to build up our dental implants of greater consistency and of a more firm consistency as well, which we know that is going to be playing a key factor in the prevention and also in the management of peri-implant disorders. Of course, this is providing of different physical properties to our dental implants and also to the natural dentition. The significance and also around dental implant has been a subject of controversy now since mid of phase. And this is probably because of different features. First of all, because at the beginning, most of the implants that were being studied were machine surface. And we know that surface microtopography have enhanced the process of osseointegration. But at the moment that we have the implant surface exposed to the oral cavity, we're going to have a great niche for all these bacteria to grow up and, of course, to perpetuate this chronic inflammation. Because most of the studies that were carried out were mainly performed by the Scandinavians. And it is known in all the sciences, in all the medical sciences, that the Scandinavian populations are not really completely extrapolable to the general standard for everything, and of course to oral hygiene measures. Therefore, I think that as we're going to see in the following slides, it makes sense for us to try to promote keratinized tissue around our natural teeth and, of course, around our consistency, which can, of course, have an important impact on the bacterial penetration towards the implant surface, which can chronify the disease. Regarding consistency, it should be noted that clinical findings have shown that those patients with at least a band of more than 2 millimeters of keratinized tissue around the dental implants, they're going to report more comfort during brushing. And understanding that the primary etiologic factor for periimplantitis is bacterial plaque in a susceptible host, of course, we have to manage media in order to provide a better environment and to provide better conditions for the patient to have good personalized, administered oral hygiene measures. Into the bargain, it must be noted that the lack of keratinized mucosa has been further associated to other conditions. For instance, in this interesting study, it was demonstrated that those individuals with less than 2 millimeters of keratinized tissue around the dental implants are further exposed to a shallow vestibular depth, less than 4 millimeters. And of course, that's going to interfere in the capabilities that our patients have to read the implants. Another interesting fact is that the lack of keratinized mucosa has not only shown to be detrimental on the peri-implant environment at the clinical level, but also at an immunological level, exhibited that those implants lacking keratinized mucosa on the buccal aspects, they were exhibiting greater pro-inflammatory profile by means of PGE2, which is a prostaglandin E2, which is going to favor a more. It makes sense to understand the findings published by Francois, showing that when in humans it's induced peri-implants mucositis and it's tried to be managed by means of mechanical therapy, in those implants lacking keratinized mucosa in the buccal aspect are going to display a more aggressive onset, also a more erratic or efficient resolution of the disease when applied a mechanical therapy. And as I said at the beginning, much has been the evidence published within this subject showing to have beneficial outcome at dental implant sites, and others, on the contrary, have shown that the dental implants has a negligible effect and association for the peri-implant environment. But in this sense, dear colleagues, I think that it really makes sense for me to look after over than 100 than a century of understanding and investigation that we have in the field of the disease of periodontitis, where we have found that, of course, the lack of keratinized tissue or keratinized gingiva at natural teeth may have a detrimental impact on the periodontal environment. And of course, that can lead to periodontitis. This you can find in the left side of the presentation, which is the Kennedy study. This can help to understand everything, not only around natural teeth, but also around dental implants, and how it's also important to conceive in a different settings and also in different environments the clinical studies published within these different settings and clinical. It was shown that in a prospective manner, when patients were randomly allocated into having no keratinized gingiva at natural dentition, or having a gain of keratinized gingiva by means of free gingival graft, it was shown that in a prospective manner, this didn't really have any association with the periodontal conditions. But there, which is showing that when those implants were no longer evaluated in a prospective manner, therefore they didn't have to undergo into a supportive periodontal therapy, most of the ones that didn't enroll in this free gingival graft at baseline, they developed signs of inflammation, developed signs of mucosal recession. Therefore, this is explaining that well, and of course, keratinized mucosa is not really pivotal. On the flip side of the coin, or that they are inefficient in doing personal administered oral hygiene measures. In these patients, of course, keratinized mucosa is going to be playing a key role in preserving health around not only natural teeth, but also around dental implants. And in light of that, we published one study which 2 years ago already, 2018, together with my good friend Gonzalo Blasi, to assess was the influence of the band of keratinized mucosa around dental implant in those cases that are undesired, in these erratic maintenance compliers, patients that can only once or not even once per year. This means that these are going to be patients that are going to be irregular, not only in compliers, but also understanding the studies in the field of psychology. These patients tend to be more smokers, tend to be more erratic also in their personal administered oral hygiene measures. Therefore, these are going to be patients that we have to presume that they're going to accumulate more plaque and biofilm at their dental implant. And what was shown in this study was that, first of all, in these erratic patients, the band of keratinized mucosa aspect may play a significant role in the comfort. Therefore, these patients are more efficient, more effective when brushing their dental implants. But not only that, we found out that there is a difference of about 40% erratic patients with the same profile, but some of them with a local distinguishing factor, which in this case is the band of keratinized mucosa, and for those that lack of keratinized mucosa. And therefore, for those individuals with 2 or more millimeters of keratinized mucosa, only 4% of these erratic maintenance compliers develop the disease, while for those patients that lack keratinized mucosa at the buccal aspect, 44% of these develop this disease. And of course, we know how challenging and how unpredictable it is to manage this. And in this type of patients, we have to think that if we want to efficiently manage the disorder of periimplantitis or periimplantitis, there is not only the prosthesis, which of course are important points, but also and also on identifying which are the local predisposing factors that in this case. Therefore, dear colleagues, if we have in a scenario of periimplantitis, lack of keratinized mucosa, first thing that we have to go is to soft tissue conditioning, to change the environment. Because if that local factor led to the manifestation of this disease at that particular implant or implants, that means that's going to be playing an important role in the resolution of disease or in the failure of the treatment, and therefore an effective resolution, which of course will recur and will have the same scenario. And that's something that really upsets me in the management of periimplantitis, because we commonly understand that it's very difficult, it's almost impossible to manage efficiently periimplantitis. But I think that the key is really to identify these local predisposing factors, to assign an accurate prognosis, and therefore to apply an intervention accordingly. But if we have the scenario where we want to increase the keratinized mucosa at periimplantitis sites, the evidence has shown with an autogenous graft is efficient in order to augment the band of keratinized mucosa and also to reduce the inflammatory clinical signs of disease and to maintain more stable bone levels. And therefore, I think that we have dealing with lack of keratinized mucosa in periimplantitis implants. From the left to the right, you can see a dehiscence type defect, where there is a unique feature which says that the implant is inside of the bony housing. And of course, we're going to have a reparative potential from the bone and also for the soft tissue. The second key scenario is probably, it's associated to a lack of keratinized mucosa, but the implant is for the outside of the bony envelope. The third case scenario on the right side of the presentation the implant is inside of the bony envelope, but it's displaying no longer a dehiscence type defect, but in this case, an infrabony in the left side, which is the most straightforward condition. Again, this is when the implant is within the bony housing. It may have developed as type defect and is associated to a lack of keratinized mucosa. In this type of scenarios, we have to cautiously evaluate which is the clinical and also which is the radiographic scenario. You can see that this clinical image is clearly displaying an inflammatory tissue, lack of keratinized mucosa, with a very shallow vestibular depth. And when we retrieve that this patient is not really accurate in having an adequate personal lab, this is not really providing comfort while brushing around the dental implants. First thing that we must do, it's always to apply a non-surgical therapy. In the management of periimplantitis, no matter the intervention you're going to apply, the non-surgical therapy by means of pharmacologic or chemical agents, it's of course always encouraged for many reasons. First of all, to evaluate whether the patient is able to self-repair or self-resolve the disease. Secondly, because we are trying to accommodate these tissues by means of a surgical therapeutically in the entail flap management, it's much better to have a plaque-free environment. And after we have that, the flap should be outlined. The flap should be outlined using the apically position, or there are in some cases, such as in the posterior mandible, where we should get rid of part of the mucosa in order to avoid the relapse of it, which of course that collapse may eventually to, we have to harvest an epithelial graft. Is possible with laminar consistency, and the key of this type of grafts is going to fall on the bite joint with the margin of the flap, on the proper stability, which is green, and also by providing a vascular bed. It should be, of course, outlined that should be at least 2/3 of the total dimension within a vascular bed. That means that we have to prepare the flap with a split thickness design in order to leave the periosteum and the connective tissue below to have better neovascularization, the anastomosis of the vessels, and the stability should be achieved by means of suturing not only the flap in the apical portion, but also the graft at the lateral sides. No movement or no frenum pull should be at the end of the surgery. And here you can see the early healing, which is characterized by a minimal in the next few slides on which situations we may anticipate more shrinkage, more dimensional changes of the grafts. But of course, the anterior mandible and the anterior maxilla are not the areas that are exposed to excessive dimensional changes. And after 3 months of healing, we can see that the tissues, we are not only dealing with a better environment, so the patient is really more comfortable by means of personal administered oral hygiene measures, but also the stability of the peri-implant tissues in a scenario that have 3 millimeters of bone defect defects at baseline, now we can see that our probe is not penetrating beyond 1 to 2 millimeters, because this firm consistency is not really leading for the plaque to migrate apically and therefore to have a recurrence of the disease. Now, this is a surgery that is highly satisfying for us because it's really providing comfort for our patients that were incapable to efficiently remove the plaque around their dental implants. Now, these patients report complete comfort for the use of superfloss or interdental brush in order to have an inflammation-free environment. We have here another scenario pretty similar, also in the anterior mandible, characterized by the lack of keratinized mucosa. But when we evaluate the implants in a three-dimensional perspective, we can assess that the implants are within the housing. In this case, again, we must do non-surgical therapy by means of mechanical therapy using anyways. And also we can help ourselves by using very cheap agents such as the chlorhexidine at 0.12% in a submucosal manner in order to better manage this inflammation confined in the soft tissues. And after we have achieved that, the graft should be harvested from the palate. Again, you can see that these are not thin grafts at all. We are talking about 1.5 millimeters in these areas that we are trying to compensate the lack of buccal bone with keratinized tissue, and therefore they should be appropriate and the connective tissue underneath. And again, stability should be provided by means of bad joint connection with the margin. Of course, keeping in mind that the graft should be secured in a vascular bed, which is going to be provided by the periosteum underneath, and of course that we should not overestimate the potential of these free epithelial grafts, because if we leave the epithelial graft exposed to an avascular surface over than 1/3 of the overall soft tissue dimension, we may face the scenario of necrosis of the whole graft. And of course, this is not going to really help us in order to achieve the expected outcomes by means of gaining keratinized mucosa, and also in order to improve and to resolve disease. In this case, you can see again the early healing and the late healing, which has been characterized by the loss approximately of 40% of the overall graft dimension at baseline. But now we are dealing with a scenario which is displaying of 2 millimeters with no bleeding on probing whatsoever. Therefore, we have shifted completely the exhibiting dehiscence type defects into implants that now, because of the gain in soft tissue, not only by means of quality, but also by means of quantity in terms of thickness, now it's going to be providing a better environment for these implants to have a long-term health or long-term success. No matter which endpoint you want to fix in your prognosis, this is going to fall in both of them. Let's see another case scenario: lack of keratinized mucosa, exudate or suppuration. We can see that the tissues are pretty inflamed, but the implant luckily is within the bony housing. This type of scenarios, we have to do a split thickness flap, leaving exposed the periosteum and, if possible, the connective tissue. And after the graft has been harvested, it should be stabilized not in a coronal dimension, but rather in an apical direction. Because in fact, this free graft contains all the cellularity that is tissues in order to have this desired keratinization, in order to provide these beneficial physical properties for our dental implant, which again, it's going to seal the periimplant sulcus in a more efficient manner. And of course, it's going to provide our patient of more comfort during brushing. And here you have a follow-up, which is featured by a lack of residual pocket. And of course, the patient now can achieve a plaque-free environment by means using these interproximal brushes. And as you can see, of course, we have been able to deal and to resolve the disease in a very efficient manner just by means of soft tissue conditioning. Because in these type of scenarios, again, the key falls in the fact that the identification of these local predisposing factors is crucial in order to achieve adequate long-term outcomes. Let's see another scenario. Again, a straightforward scenario, very predictable separation, bone loss around the dental implant in the buccal aspect. But nevertheless, since we are dealing with an implant which is inside of the bony housing, a split thickness flap should be drawn in order to leave a vascular bed for the graft to be stabilized. Of course, if we have identified another local predisposing factor, such as the inadequate emergence profile characterized by an emergence of greater than 30 degrees, therefore we are dealing with a convex emergence profile, this should be changed and be stabilized. It can be noted the early healing characterized by this pinkish color, which means that the anastomosis and the newly formed vessels is occurring within the newly band of keratinized mucosa, which has been provided by the free epithelial graft, and the late healing, which of course is not only providing a band of keratinized mucosa, but also it's supplying of vestibular depth greater than 4 millimeters in order to assist the patients to achieve a plaque-free comfort during brushing. Let's go now through the second case scenario. This is more challenging because the prognosis of this is more compromised. You have to keep in mind that the implant is outside of the bony housing, meaning that the implant micro roughness is going to be more exposed to the biofilm, which can perpetuate the disease. Therefore, I claim for a more cautious evaluation in this type of scenarios, and of course, to evaluate whether it's worth to save this implant, or whether on the flip side of the coin, to start over. But let me show you some of the cases which, of course, the implant retrieval was not an option for more than evident characteristics, in this case because of the implant is approaching to the maxillary sinus, there is a lack of keratinized mucosa, and the implant is outside of the bony house, and you can see that it has been lost over in the half of the dental implant. Nevertheless, considering and putting in a balance the pros and cons, and understanding, of course, which is the effectiveness of this type of therapeutic modality, we can provide longer time for this implant to be supporting these fixed prostheses in the mouth of this patient. And again, one of the features of this case scenario is that the implant is outside of the bony housing, and therefore here we have to modify the technique, because conceiving that there is a null reparative potential at the buccal surface of the dental implants, and understanding that the goal is to provide a band of keratinized mucosa and not to have a recession coverage, we must anticipate that the buccal aspect of the implant is going to be exposed to the oral cavity, and therefore a surface modification by means of modifying the surface, it might be convenient in order to avoid, or at least to minimize the plaque. In these cases, of course, another thing that should be stated is that we are not really trying to compensate null reparative potential, but rather to provide keratinized mucosa, and therefore it is claimed in this type of scenarios to harvest a thinner epithelial graft, because the size of the gingival graft, not only by means of length but also by means of width or thickness, it's going to really be playing a key role on morbidity of the patient. Therefore, if we can minimize the morbidity, the patient. In this type of scenarios, we have modified, as you can see in this image, two interventions which are linked to this type of therapy. We have modified the implant surface by means of implantoplasty, and secondly, we have harvested a thinner epithelial graft, which, of course, we have to keep in mind the thinner grafts as described by Morman in 1980 shrinkage, but we have to anticipate that in order to have enough keratinized mucosa at the end of the healing period. After these two differential interventions have been carried out, we can see that after the stability of the graft is in keratinized mucosa, of course, to improve the clinical situation by means of reducing probing pocket depth, which, by the way, we have to reach a probing pocket depth less than 5 millimeters with no bleeding and with no progressive bone loss in order to succeed. That is, no matter what type of therapy you want to apply. Let's say another more challenging scenario, happening in an individual with active periodontal disease, with severe inflammation, an implant which is outside of the bony housing, as you can see, and moderate to severe bone loss. In this case, again, we have to identify which are the prognosis factors, which in this case is the identify and anticipate, of course, that the buccal surface of the implant is going to be exposed to the oral cavity. And in order to minimize plaque accumulation, a surface modification by means of implantoplasty should be performed in order to guarantee and maintain the pre-implant tissues. And keeping in mind one of the first notions that I provided at the beginning of the presentation, which was that it is encouraged that no more than 1/3 of the overall graft dimension it's exposed to an avascular surface, such as the implant surface, the graft should be pulled apically in order to make this going to happen uneventfully. And here you can see which are the outcomes at 15 months of healing, where we can see that it has been successfully managed by means of resolving the inflammation, the augmentation of the keratinized mucosa, and of course, to provide a better environment for the patient, we have been able to deepen the vestibule to this particular area, so the patient now may feel more comfortability and more access to reaching this area by means of personal administered oral hygiene measures. Colleagues, we have published an article which is already accepted since August, and hopefully will be outside soon. We're compiling this type of scenarios with these two different key scenarios, but of course, periimplantitis cases lacking keratinized mucosa, we were able to demonstrate that it was possible to efficiently manage this type of scenarios by means of no even one spot of bleeding on probing no progressive bone loss in about 9 out of 10 implants. That means almost 90% of the patients. Therefore, if we are able to certainly identify this type of periimplantitis defects associated with a lack of keratinized mucosa, first thing we have to think is on the local predisposing factors. And this means conditioning by means of free epithelial graft. But see how important it is to provide patients of a therapy, that when we ask the patients at the end of the follow-up whether they felt more comfortability when brushing the dental implants, for all those cases that demonstrated to be completely successful with no even bleeding on probing, they noted 100% of satisfaction during brushing. While for those patients that were not the disease, because there were still a few spots of bleeding on probing, or at least one, which was also considered unsuccessful or failure in the management of periimplantitis, which of course this is a subject of debate, but we can arrange another webinar for that, Omid. These patients didn't really express complete satisfaction while brushing the dental implants. This means that the patients can certainly provide us an accurate indicator of disease presence or disease recurrence or disease resolution. So we have to communicate and we have to listen to our patients in order to have their feedback and know whether we have management of periimplantitis. We further shed light on the dimensional grafts after have been used for these particular scenarios. And it was found that overall, the average grafts shrink in a mean of 42 to 45% of their baseline dimension. But an interesting observation was the fact that in the posterior mandible, these cases are exposed to greater, which were actually the implants that were not completely resolved after applying this therapeutic modality. And this is basically because of the pull provided by the masseter muscle. And hence, in these scenarios, it is encouraged, first of all, to their muscle, and of course, being perhaps even more aggressive by means of the gingivectomy or by means of removing the flap, the mucosal flap. And of course, we have to anticipate for this greater shrinkage, and thus, based on that, it might be advised to harvest a greater epithelial graft by means of weave in order to anticipate for this 70 to 80% of shrinkage, and at least anticipate that we're going to need 2 millimeters of keratinized mucosa in order to provide further 4 millimeters of vestibular depth in order to provide our patients of great comfort during brushing. But you have to agree with me that one of the major these free epithelial grafts is that they are associated to a high morbidity for the patients, and somehow this can also affect the acceptance of these patients to undergo to this type of therapy. And therefore, we have recently proposed, and we have submitted already for publication together with a very talented guy from the University of Michigan, Lorenzo Tavelli, and the masters in soft. We have modified the technique that we knew that was sufficient in order to augment the keratinized mucosa around natural teeth. We have modified it accordingly for its use in the management of periimplantitis. And therefore, in these cases that we don't really want to expose the patient to a great morbidity, can advocate for the use of this connective tissue rotated flap. This is a graftless technique rotated over the implant surface, has been secured, and based on that, now it was possible up to 30-month follow-up, what we have so far, with an adequate band of at least 2 millimeters of keratinized mucosa, as you can see, and completely free of inflammation in a scenario that was displaying overt bleeding, overt suppuration, and of course, progressive bone loss. Another key factor in the management of these type of scenarios is the fact that osteoplasty and ostectomy together we carried out in this type of scenarios that should be tailored according to the initial, of course, position three-dimensional of the implants. Let's see another case, an implant, adjacent implant bleeding on probing suppuration after the application of non-surgical therapy, where again, we have to do a surface modification, the plasty of the hard tissues as well. And in these cases, we can roll over a flap which has been de-epithelialized, and once it's rolled over and stabilized over the buccal aspects, we can see that this is not only in mucosa, but most importantly is to shift the prognosis of these dental implants, which previously were implantitis, and now there is no pathologic probing depth greater than 5 millimeters. Therefore, now we were able, with a graftless technique, to provide these patients of a better environment, which is going to play a crucial role in the prognosis. You can see here the design of the connective tissue rotated flap. In this sense, also, we can take advantage of new applications by means of the techniques, and also by means of the incorporation of new biomaterials. Here you can see a case again of periimplantitis of adjacent implants with an uneven bone topography, which of course it must be undergo to osteoplasty or ostectomy. But you can see that in the distal implant, there is no keratinized mucosa whatsoever. And the availability of keratinized mucosa in the adjacent area, try to slide it, try to rotate this band of keratinized mucosa to provide sufficient cells in order to migrate coronally, and adjunct it with the use of collagen as scaffold for the cellular migration towards the coronal aspect of this type of lesions. And once this has been achieved, you can efficiently manage the disease, that there is no probing depth greater than 2 millimeters, and that therefore the prognosis is completely in a very efficient manner, and where, as you can note here in the presentation, it has been evaluated at the baseline, which are the local predisposing factors. And one of them, of course, was that the implants were only housing, therefore they required surface modification, that this periimplantitis was associated to a lack of keratinized mucosa, in particular in the distalmost implant. And last but not least in importance is the fact that, as you can see, I modified the prosthesis this time, and now is providing a patient good access and capability for oral hygiene measures. Nevertheless, we have to keep in mind that these type of scenarios are not plausible in the mandible. We cannot really roll over the flap from the vast majority of the scenarios we lack of keratinized mucosa in the lingual aspect, and also because of the anatomical boundaries that we in that area. Therefore, we claim for a modified technique in these areas, we can certainly check the availability of keratinized tissue adjacent to dental implants, try to do a lateral sliding flap. Again, this is a graftless technique because it doesn't really tissue graft or any free gingival graft. Try to accommodate it and secure it in the area that needs mucosa. Try to compensate the area, the donor side, with the collagen membrane or with the collagen metrics in order to also develop keratinized mucosa in that area. And as you can see in this area, we efficiently resolve this periimplantitis by means of soft tissue conditioning with lateral sliding flap, a grafted technique, and also by modifying the prosthesis and provide the patient of a better environment for oral hygiene measure. Because this is, hopefully, this is one of the take-home messages that you can really embrace, and is the fact that periimplantitis is a biofilm-mediated inflammatory condition. This means that the prosthesis doesn't really cause the disease. The lack of keratinized mucosa, the operator causes disease. What causes the disease is plaque. But it's true that we have certain key factors that predispose this plaque to be in contact either with the prosthesis or with the abutment or with the implant surface. And when biofilm reaches the implant micro roughness surface, that's going to perpetuate. We are able to detoxify the implant surface, and we are able to resolve the disease. So far we have been exposed to two different case scenarios, but also, this is less frequently, but also we can find it, which is featured by an implant which is within the bony housing with contained or partially contained periimplantitis defect morphology, a circumferential, a three-wall morphology, which of course there is a reparative tissue, and where we want to optimize all the resources in order to build up the hard tissues, and later in a second step to prevent the recurrence. Therefore, in this exceptional case, I will say there is associated with poor oral hygiene, associated with periodontitis and inadequate prosthesis design, which was designed, the implants were placed too apically, and also the lack of keratinized mucosa that in the early stages, of course, I'm sure that mucosal recession. So in this type of a scenario, we must identify issue that general therapy for periimplantitis implants, and it's the fact that we should not really be so ambitious by means of regenerating all the hard tissues, but to identify which is the reparative potential. And the reparative potential, as you can see in the image in the left side of the presentation, indicated with a probe, it's really outlined by the lower peak of the implant, or from the bony peak towards a parallel. This will indicate how much it's possible to be augmented by hard tissues, and how much is going to be exposed no matter what type of intervention you apply, no matter how good surgeon you are. That at the end of the day, if we don't have the containment of the adjacent bony peak, it's gonna collapse. And anticipating to that, it must be done a surface implantoplasty, and the area that can be augmented biomaterial. In this case, it was applied an allograft, but we're going to publish a key series with very promising outcomes showing that we are able to deal cases of periimplantitis exhibiting 2 or 3 wall defects by means of an organic bone and, of course, a resorbable barrier membrane. About 8 out of 10 implants with periimplantitis. Again, that might be, we can find out another opportunity in order to share these findings for you, because I think that they're very very elucidating for you to follow, and most importantly, to identify which implants can be treated and with prognosis, no matter what therapeutic modality you apply. But in this case, we applied an allograft with a resorbable collagen membrane. And after a decent healing of 4 to 5 months, soft tissues were epithelial graft, and you can see the follow-up at 12 months, where it was shown that in such an advanced case of periimplantitis, now this keratinized mucosa combined with the augmentation of the contained area by means of able both together to compensate this probing pocket depth, and nowadays there is no bacterial penetrant surface in order to perpetuate the disease or lead to a recurrence. And in this time, the key falls on the fact that it was possible to change the prosthesis design. The patient was instructed to apply an adequate oral hygiene measures, and most importantly, because now the keratinized mucosa on the buccal aspect of the dental implant is providing a physical sealing, so the bacteria cannot really penetrate. Should be noted, and it can be very clearly displayed in these two images, that one key factor, of course, in the management of periimplantitis is identifying this reparative potential. And by this means, in the supracrestal area, we have to foresee that the surface at the coronal aspect of the implant is going to be exposed, and anticipating to the pivotal role that plays that on biofilm attachment into the micro roughness, I think that it really makes a lot of sense to do surface modification, try to modify the surface by means of implantoplasty, and provide a better environment for these patients which already have prognosis. And let's see the last case of the presentation, again showing this type of clinical outside and inside of the bony housing, but the fact is that regeneration can be applied for the infraosseous component, and which are further associated with a lack of keratinized mucosa. You can see the overt bleeding on probing pocket depth, which of course is greater than 5-6 millimeters, inflammation of the soft tissues, and the implant which is already exposed to the oral cavity. According to a recently published classification by our group together with Frank Swartz, we can classify this as a probably advanced, since it's exceeding more than 4 millimeters beyond the initial physiological bone removal surgical image, where the biofilm and the calculus is attached to the buccal aspect of the implant. There's no way to detoxify using chemicals this implant surface. And according to have provided along all this presentation, I think it's convenient to apply implantoplasty at the buccal surface, applying the principles of guided bone regeneration in order to optimize guided bone regeneration in the infraosseous component of this periimplantitis, anticipating, of course, that the implant is going to be exposed to the oral cavity. And in a second stage, after the implant has been, after the bone has matured or is undergoing maturation, a split thickness flap can be drawn in order to place a very tiny, very minimal band of keratinized tissue harvested from the palate, which is going to provide a better environment for the patient. You can see that the probing pocket depth has been significantly reduced, that by means of radiographic analysis, there is bone gain. Of course, this is not really completely comparable, I will say, with health if you only look at the radiograph, because it's missing the buccal as constructed, because the implant is partially outside of the bony envelope. Therefore, the reparative potential by means of bone, it's non-volume stable barrier membranes. And therefore, assuming the scenario, assuming the three-dimensional position that we have, I think that we have considerably improved the prognosis of this implant by providing a better environment, by providing a more consistent implant surface, less attractive for biofilm to build up, and therefore the per-implant health here is guaranteed as long as the patient is really accepting and performing personalized administered oral hygiene. All in all, dear colleagues, I hope I persuaded you on two important facts. First of all, is that for me, I think it makes sense that in the Mediterranean countries, in North America, South America, of course, in Iran, in Asia, we have to claim for mucosa around our dental implants, not only to prevent peri-implant disorders, but also to manage keratinized mucosa. And also that the free autologous epithelial graft has shown to be efficient, not only in augmenting the band of keratinized mucosa, but in after the adequate identification of the case scenario to efficiently resolve periimplantitis. That in those cases that are exhibiting supracrestal component or the Hissens type defects, the surgical intervention should not only encompass surfacing, and also by getting rid of the inflammation by means of the thorough debridement of the soft tissue, but also in soft tissue conditioning by means of free autogenous epithelial graft. That also we should keep in mind the notions provided of periodontitis by means of assisting ourselves by using lateral flaps in order to augment the band of keratinized mucosa and also desired band to improve the clinical parameters around our dental implants. In other words, to have per-implant health in a long term and provided patients of greater satisfaction. With all this, dear colleagues, it was my pleasure to share with you some of our findings, some of my personal perspectives, some of our experience, of course. I would like to thank you for your very kind and I'm sure enthusiastic attention and time. I wish you, I hope that you really look to the future with a more optimistic I will say we don't really know how long it's going to last this, and it's better just to smile home, to enrich our knowledge, to take advantage that this situation is going to really providing us a lot of time in order to enrich our knowledge, to be with our family. And of course, I wish you and your family all the best to be again, I want to insist on the gratefulness that I have to my good friend Omid. First of all, for this initiative, for arranging this. Secondly, because I know that we're going to have so much fun next year when I go to Iran. And I wish your country also all the best international situations, because for what I have heard, it's probably one of the most beautiful countries the human being can be from a historical perspective and also from their people. So I wish you all the best, and I look forward for any queries if want to be addressed at this moment.
Thank you, Alberto. I really enjoyed your comprehensive presentation on periimplantitis. And we will have a little question and answer. But before that, I would like to say that Alberto is going to be one of our keynote speakers at the 5th International Symposium of Complications in Implant Dentistry next year, 2021. From July, actually the event's going to be in July 13 to 16. So looking forward to welcoming you in Iran. As I said, we really enjoyed your presentation. One of the things I really recommend to the audience, one of the articles you on classification of different defect types around pre-implantation disease cases. I think it's important to know about that classification because each defect can dictate you a different approach. And at least if you want to increase the predictability of the outcome that you're going to gain, you know exactly what was the etiology and how is the defect shape, is it in the inner envelope, outer of the envelope. So definitely it will have an influence on the decision that you're making. One of the things that I noticed in your presentation was that in most of the cases, the trend was to try to save those implants. And it's, I think, very good because many clinicians usually very fast, they decide to explant the implant and won't try any periodontal approach to try to save those implants. As we saw in your cases with the implantoplasty, with filling the tissue, most of the cases heal perfectly. And usually when we are in the social media, so many dentists and specialists try to show the best scenario in treating the patient. But usually I think one of the things that we have to keep in mind, we need to help our patients to save their implants, save their teeth, if we can do it with a periodontal approach. And as I mentioned, in most of your cases, you did that, and your main goal was not just aesthetic, but health. I think I want to know if you agree with me.
Correct.
Yeah, because it's, I think. Yeah, please.
Go ahead. No, please go ahead.
Because I think one of the main things that we have to keep in mind in treating our patients, first we should diagnose what was the etiology behind that problem. And if we can solve that, I think we can save. But depend on the case, if it's in the aesthetic zone, depend on the patient demand, then the scenario can be different. But overall speaking, most of the cases we can save those implants as we can save most of the teeth.
Yeah, of course. Yeah, I completely agree with you. It can be indicative of the prognosis, or at least the therapeutic modality or the decision making that we can outline in the management of periimplantitis. The first thing that comes to my mind is always to retrieve the dental implants. I have to be honest with you, because of course satisfying to manage periimplantitis. Of course, communicating with the patient that they have a disease when they were promised to have this fake third dentition for as long as they last in the earth. Secondly, and most importantly, I think it's the sequela that can really leave the dental implants. And in this sense, I think that we still don't really have clear guidelines in the management of that have been previously retrieved due to periimplantitis. We have to keep in mind that periimplantitis progresses with non-linear progressive fashion. That means that most of the periimplantitis cases that we're going to be diagnosing in our dental practice are going to be severe. And of course, when we extract a tooth, it is likely that if it's for periodontal disease, probably it's going to exhibit a supracrestal component. but is because of other issues such as fractures or aesthetic demands. We're going to be dealing with completely. But of course, the management is very straightforward. It can be undergo to ridge preservation, subsequently to implant placement, or immediately to implant placement. We have, of course, understood that immediate implantation is predictable, at least from the functional standpoint. But now, when it comes to dental implants, we are dealing with very erratic morphologies. The vast majority of the morphology that we showed in that paper that we published 1 year ago was that 55% of the periimplantitis case scenarios exhibit a 2 to 3 wall defect. That means that if we extract the implant, we have to somehow reconstruct. Keep in mind that when we extract the tooth, it's the granulation tissue is very easy debrided. On the flip side of the coin, when it comes to dental implants with periimplantitis, it's more convenient to flap the area, try to eliminate all the inflammatory tissue, all the debris, all the infection that might be acute at that moment, and therefore I hesitate that at that moment it's convenient to do guided bone regeneration for alveolar or for implant site development. In this case, if we want to face in the future these cases with an implant. Therefore, with all these items as explained you, my take-home message for this is that, of course, we have implants that because of function, because of aesthetics, but in particular because of function, because of biomechanical demands from the patient. Let's imagine that we have a patient, where some of the ones that I showed you, that invested 5 years ago a lot of money in one fixed prosthesis, 5 dental implants, and now we have to tell them that 1 or 2 dental implants have to be replaced in the future, and also that the prosthetic device has to be further changed. That means that that's going to hurt not only in what refers to the communication, but also to the pocket. And when it comes to the pocket, that's more efficiently managed with the patient. Therefore, the first lesson learned, I will say, that is to save those implants that are in this type of demand. And secondly, I think that nowadays we have good data that can show us which are the indicatives for the implantitis. As such, in those implants exhibiting a severe defect, over than 50% of the overall length of the implant, the prognosis is more questionable, is more poor, and therefore we have to think in this type of scenarios whether it's worth to invest money, at least in the management of periimplantitis, or just to go all for start over implant therapy. Secondly, whether we're going to be able to manage the local predisposing factors. For me, it doesn't really make sense to go for soft tissue conditioning if I know that the prosthesis design is not really adequate in order to provide the patient access and good capability for having an harmonious oral hygiene measure. So it doesn't really make sense for me to make the patient undergo to a surgery when at the end of the day I'm going to have recurrence. Other issues that we have to keep in mind, and of course that we recently demonstrated, or we are here on patients that exhibit high scores of circular bleeding index. This means that these patients that are exhibiting very profuse bleeding to be erratic in what comes to compliance. They used to be less efficient when doing oral hygiene because not all the patients are really eager to do personal oral hygiene by means of an interproximal brush we have to assume that we might be guilty somehow in perpetuating the implant itself, with the implant design, with the implant position, with the process this disease. But of course, the patient is the one which is who is suffering the disease, and of course, they also have certain risk profiles that can really predispose these scenarios to be more towards failing in what concerns to inadequate oral hygiene and, of course, inadequate professional administered oral hygiene measured by means of supportive periodontal and peri-implant therapy at least every 5 to 6 months. So trying to pull all these factors, I think that we have to shuffle somehow our cards and try to gamble for our best choice. And if we are sure that this patient has a risk profile that we're going to be able, if it's not an adequate profile, to a good risk profile, where we know that the patient is really going to have good oral hygiene measures and so forth, and that we're going to really provide a good local environment in order to succeed in the management of periimplantitis, and therefore in order to prevent for the recurrence of disease. Of course, we should manage this case scenario. If the patient is not really willing to have good oral hygiene, to incorporate or to adhere in a very comprehensive and strict supportive periotherapy program, or if he or she is not eager really to pay for a new prosthesis or to pay for this modification of these local contributing factors, of course, it doesn't really worth all our efforts, and it doesn't worth the money of the patient.
Thank you, Alberto, for the comments. As I said, we really enjoyed your presentation, and as you said, hygiene, thickness of the tissue, and definitely thickness of the bone are the key that we can keep in mind for preventing the problem first for our patients, and then think thoroughly about our patient, think that we can put our family members beside and think that what is the best treatment for the patient, not just only related to the money or the advancement of the surgery. We can go always with our patients, and as you said, listening to the patient's demand is always a key in our making. With that said, I want to thank you all again for joining us in this webinar. Thank you again, Alberto, for sharing your amazing presentation with us. I really recommend you all follow Alberto Monje on his Instagram page, and it's full of great stuffs and his articles, cases. You can get a lot of ideas. And don't miss 2021 Complication Symposium in Tehran. Definitely, he will be with us with lots of amazing stuff. Thank you again for joining us. Thank you, Alberto, for your amazing presentation.